In this presentation, I'll be mainly discussing the esophagus. I'll have also some slides on the stomach to facilitate the TBL session. I would like to remind all of you that the material that you are responsible for is all included in your handouts. Swallowing. The passage of ingested solids and liquids through the esophagus is accomplished through a coordinated series of motor events. The chewed food is transferred from the oropharynx into the upper esophagus by voluntary pharyngeal contraction that is synchronized with the relaxation of the upper esophageal sphincter. Next, food is transported down the esophageal body by peristaltic contractions, and finally the food enters the stomach during the relaxation of the lower esophageal sphincter. Gastroesophageal reflux. Between swallowing, the components of the esophagus serve to prevent the retrograde flow of gastric contents. The usually tonically contracted LES and UES prevent such reflux. If reflux does occur, the esophagus clears this material through secondary peristalsis. Control mechanisms. The UES receives motor input from the brainstem via tonic excitatory neural discharge to the cricopharyngeus. In the esophageal body, central control of peristalsis is more important in the striated portion, while in the smooth muscle portion there is probably central and intrinsic mechanisms involved. The tonic contractions of the LES are predominantly due to intrinsic smooth muscle activity and some components of vagally mediated cholinergic control. This is a very important slide. It shows you pretty much a lot about what you need to know about the physiology of the esophagus and swallowing and peristalsis. If you look on the left side of the slide, you see the pharynx, and then you can see the components of the esophagus that we had discussed. the upper sphincter, body of the esophagus, and the lower sphincter. On the right side, you can see pressure reading, indicating how the food bolus is moving from the upper esophagus to the lower esophagus. If you look at the uppermost component, you can see that there is a spike at the level of the pharynx, which tells you that there is basically a high pressure, and this is due to the contraction of the pharynx to get the food down into the upper or through the upper sphincter. If you notice that at the same time, look at the line, at the vertical line, at the same time when there is a peak of pressure in the pharynx indicating contraction, there is low pressure or relaxation in the tonically contracted upper esophageal sphincter. And after this dip, there is a rebound increase and then going back to the baseline high pressure in the upper sphincter. If you look at the third part of the pressure tracing, you see that there is a pressure wave which is indicating how the peristalsis is moving the food bolus, and the second one the same, and the third one the same, but it's moving along a timeline. That is, it's not along the same vertical line, but it's moving a little bit more to the right every single cut from the upper esophagus to the lower esophagus, indicating that the food bolus is being carried down the esophagus body and to the end of the body of the esophagus. At the same time, when the food bolus reaches the lower sphincter or the lower esophageal sphincter, it's already relaxed, so food can go straight to the stomach without any resistance from a relaxed LES. And notice that the moment you swallow, when the pharynx is contracted and the upper sphincter is relaxed, a fraction of a second later the lower sphincter would relax. So what are the symptoms of esophageal disease? The main symptom is dysphagia, which is divided into oropharyngeal and esophageal. Oropharyngeal dysphagia is the inability to initiate a swallow. This usually manifests as coughing, choking, nasal regurgitation of food upon the initiation of swallowing. Esophageal dysphagia is the sensation of food being stuck as it passes from the mouth towards the stomach. Odonophagia is the sensation of pain distinctly associated with the act of swallowing. Heartburn is the commonest symptom related to the esophagus and the cardinal symptom of gastroesophageal reflux disease that we'll be discussing later on. It's a burning sensation under the sternum that radiates towards the epigastrium. The other symptoms include chest pain, regurgitation, and hiccups that are explained in your handout. This slide shows you what happens in oropharyngeal dysphagia when there is difficulty to initiate swallowing. Again, the green component is the food, and in the second part you see that there is nasopharyngeal regurgitation, food coming out through the nose. There could be aspiration and choking to the trachea and the lungs, and it would be sometimes difficult to clear the food from the mouth and throat. Oropharyngeal dysphagia is usually caused by a variety of mechanical and neuromuscular conditions. This would show you some of the examples. Examples of mechanical is enlarged thyroid, Zenker's diverticulum, carcinoma, etc. While neuromuscular conditions include myasthenia gravis, Parkinson's disease, stroke, etc. On the other hand, common causes of esophageal dysphagia include structural abnormalities or motility abnormalities. Structural abnormalities include obstructing lesions such as strictures or carcinoma, when dysphagia is mostly for solid food, while when secondary to motility disorders such as achalasia, dysphagia is for solids and liquids together. Diagnostic modalities of esophageal diseases include barium studies, manometry, esophageal pH monitoring, endoscopy, endoscopic ultrasound, and video fluoroscopy. This is an example of barium study, which is an esophagogram, where a radiographic study is done after the patient swallows barium, which is a radio-opaque substance. This outlines the esophagus and its contents. This test is becoming obsolete, but it's still useful for some patients with suspected motility disorders or with patients with suspected mechanical obstruction. This test is called esophageal manometry. It uses a pressure sensing catheter that is inserted from the mouth into the esophagus and the stomach, but it allows the pressure assessment of all the esophageal components, the upper sphincter, the body of the esophagus, and the lower sphincter. It is the test of choice to diagnose motility disorders of the esophagus. This test is called the esophageal pH monitoring. It involves measuring the esophageal pH and continuously monitoring it using a probe that is attached to a portable pH recording device. This test is the test of choice for the diagnosis of GERD, GERD, or gastroesophageal reflux disease. This test shows you endoscopy. This is an endoscopic image of the gastroesophageal junction. If you look at the lower part of the screen, the mucosa appears pinkish, which is what the squamous esophageal mucosa looks like. Below it is the reddish mucosa, which is what gastric columnar mucosa looks like upon doing an endoscopic examination. Endoscopy is the test of choice for evaluating most of esophageal symptoms. It allows direct visualization of pathology, it allows biopsy for histopathologic examination, and opens a huge door for therapeutic applications. This test is EUS, or endoscopic ultrasonography. It's the study of choice for the evaluation of tumors. It's very important in staging of tumors in the esophagus or in the stomach, and this is important because the treatment depends on the staging of such tumors. As you can see, you can evaluate the tumor that is visualized on the lower part of the slide, and you can look on the right or the left side and see what the normal wall of the stomach or the esophagus look using this examination, endoscopic ultrasound. I'll be discussing two main diseases in the esophagus, GERD, GERD, and achalasia. The first here is GERD, which is gastroesophageal reflux disease. I'll be discussing the pathophysiology, namely the value of the refluxate versus the defenses, the importance of acid contact time, and the relevance of hiatal hernias. The pathophysiology of GERD or GERD involves the balance between offense and defense. The defense or the esophageal defenses are mainly the acid neutralization by the saliva and the esophageal mucosal resistance, in addition to peristalsis, which is supposed to clear any refluxate from the esophagus. The offense or the potency of refluxate factors contributing to mucosal damage include direct toxic injury and prolonged mucosal contact time with the gastric components, which are mainly the acid, pepsin, and bile. Prolonged acid contact time results mainly from incompetence of the LES, and this is mainly caused by the transient relaxation of the LES. When there are more transient relaxations of the LES, you get more exposure and contact time in the esophagus. In addition, hypotensive LES plays a role. Also, if there is a problem with esophageal acid clearance that comes with impairment of the peristalsis or increased frequency of the reflux episodes, then that would be also important regarding prolonged acid contact time. Finally, if there is delay in the gastric emptying, this would contribute also to the prolonged acid contact time. Transient relaxations of the LES occur in both normal individuals and in patients with GERD. These relaxations are a part of the reflex that normally allows for gas venting from the stomach, or may be triggered by funding distension with air. We all know this as belching or burping. Transient LES relaxation persists longer than the swallow-induced LES relaxation. Hiatal hernias are common and carry no significance in asymptomatic people. However, they are present in the majority of patients with severe GERD. The hernia sac, which is located above the level of the diaphragm, appears to retard esophageal acid clearance and increase the frequency of reflux episodes. So what are the clinical manifestations of GERD or GERD? There are many esophageal symptoms and there are extraesophageal symptoms. Moving to the typical symptoms, the first is heartburn, which is a discomfort or burning sensation behind the sternum that arises from the epigastrium and may radiate towards the neck. Regurgitation is also a symptom, and it's the effortless return of gastric contents into the pharynx without nausea or retching. There are other less known symptoms such as water brash and the globus sensation. Atypical symptoms of GERD include hoarseness, pharyngitis, asthma, otitis, chronic cough, or non-cardiac chest pain. As discussed earlier, the test of choice for the diagnosis of GERD is the pH monitoring of the esophagus, and basically this slide shows you that the pH is dropping to low levels, indicating acid exposure of the esophagus from around 11 p.m. to around 1:30 a.m. I will be briefly discussing the treatment of GERD, starting with lifestyle modification, what every patient can do to minimize the symptoms of reflux disease, moving to medical therapy quickly and surgical therapy.